Good afternoon or good morning to all of you, and thank you for attending our webinar, ECHO, using video conferencing technology to build communities of learning for clinicians who serve special populations. We have a few housekeeping reminders before we get started today. If you're viewing this webinar as a group, please go to the chat window and type in the name of each person registered and the total number of additional people, the person registered and the total number of additional people in the room. For example, Tammy Jones +3, and this will help us with our final attendance count. A few reminders for you all today as well. All attendees are in listen-only mode. However, we want to hear your questions. To ask a question at any point during the webinar, please use the chat box located in your GoToWebinar control window. We will address questions following the presentation. Attendees will be asked to complete evaluation questions at the end of this webinar, just to let us know how we're doing. Your feedback is vital in helping us craft presentations that meet your needs. This webinar is also being recorded and will be archived on our website. You may access our archived webinars by visiting our website at www.sbh4all.org/webinars. Today, we expect that by the end of this webinar, you'll be able to understand the Project ECHO model and how it can be used to improve patient outcomes and overall quality of care. Describe how the Project ECHO model can be used to improve treatment of pediatric and adolescent behavioral health conditions in school-based health centers, and understand how Project ECHO can promote integration of behavioral health and primary care. Before we get started today, we'd just like to know a little bit more about who is on the webinar with 3 quick poll questions. Our first poll question is asking you about what setting you work in. We're going to ask you to please take a moment to answer the poll question that appears on your screen. We'll leave this open for about 30 seconds. Five more seconds. Okay, great, thank you. Okay, based on this poll, it looks like we have 29% who work in a school-based health center, 21% in a community health center, and 50% who selected other. 0% selected a private clinic. Thank you. The second question we'd like to find out about you all today is being posted to your screen. We'd like to know, does your clinic have both behavioral health and primary health care providers? Please take a moment to answer the poll question that appears on your screen. I'll leave it open for about 30 seconds. Okay, 3 more seconds. Okay. Based on those who responded, we've got 64% who have both behavioral health and primary care providers, and 36% who say no, they do not have both providers. And our last poll to be coming up on your screen, we'd like to know, do you have any previous experience working with an ECHO clinic? Please take a moment to answer the poll that appears on your screen. We'll leave it open for about 30 seconds. Okay, thank you so much. The response to this question was that 19% of you indicated that you have previous experience working with an echo clinic and 81% say no. Thank you for responding to the polls. Today's presenters will be Darren Anderson and Jillian Hopewell. Dr. Darren Anderson is a general internist and VP Chief Quality Officer of Community Health Center, Inc. Community Health Center, Inc. is a large multi-site community health center providing primary care to over 140,000 medically underserved patients across Connecticut. As a CQO, Dr. Anderson is responsible for directing all quality improvement work across the agency. Dr. Anderson is also director of the Weitzman Institute, a center dedicated to promoting innovation in primary care for underserved populations through research, training, and quality improvement. Dr. Anderson is the principal investigator on multiple projects focused on health disparities, healthcare access, primary care redesign, and pain management in primary care. Dr. Anderson obtained his undergraduate degree at Harvard College and his medical degree from the Columbia University College of Physicians and Surgeons. He completed his residency training in internal medicine at Yale New Haven Hospital and is associate professor of medicine at the Frank Netter School of Medicine, Quinnipiac University. Jillian Hopewell has devoted her professional career to healthcare justice for immigrant populations. For the last 20 years, Ms. Hopewell has worked with Migrant Clinician Network, the oldest and largest clinical network dedicated to improving healthcare for underserved migrants. Ms. Hopewell directs Migrant Care Network's California office and is currently part of the executive management team at Migrant Clinicians Network, serving as the Director of Education and Professional Development. In this capacity, Ms. Hopewell oversees Migrant Clinician Network's comprehensive technical assistance program for migrant and community health centers and migrant clinicians. She also directs the continuing education program for clinicians and coordinates all of the clinical publications. She is the editor of Streamline, a bi-monthly peer-reviewed publication that reaches over 2,000 clinicians. Additionally, she is responsible for the development and ongoing management of content for Migrant Clinician Network's award-winning website. Without further delay, I'll turn it over to our first presenter, Dr. Darren Anderson.
Great, thank you very much, and hello everybody. I'm excited to talk to you about Project ECHO today, which I think is one of the most exciting interventions and innovations that I've seen in a long time, and I think proposes a really interesting solution for anyone who's working in primary care, anyone who feels isolated, and anyone who's interested in expanding their scope of practice and learning additional information about how to manage some of the challenging cases that they're having, that they're facing on a daily basis. And for my first day as a primary care provider at the community health center, I realized that there was an awful lot that I didn't know and that I hadn't been trained to, and I was going to need new and different solutions to acquire that knowledge, solutions that didn't involve rubbing shoulders with my specialty colleagues in hospitals or other settings, because primary care, I realized, can be very isolating. So I'm going to talk to you about Project ECHO, and what I'd like to accomplish in the time that I have is to briefly give an overview of what it is, seeing that many, if not most of you, don't have experience with an ECHO clinic, and then most importantly describe a specific Project ECHO that we've developed that is designed to support frontline providers of both behavioral health and primary care in school-based settings, which many of my friends and colleagues who work in school-based settings tell me can be, as my practice was, extremely isolating and sometimes downright lonely. So this is Community Health Center. We are a statewide federally qualified health center. We provide care in about 200 different locations across the state, including over 50 school-based health centers where we have behavioral and or medical care, and an even larger number of schools and other sites where we provide mobile dental. We also have 12 large brick-and-mortar primary care sites in different cities and towns across the state. And our providers are scattered across the state, some of them working in small practice, some of them in larger, but taking care of a wide range of patients with a wide range of challenging conditions, similar to any of you who've worked in a setting like a community health center. And as already was mentioned, I work at the Weitzman Institute, which is part of CHC, and is our center that we've created specifically to develop and promote new and innovative approaches to improving the care for underserved patients across the country. And so it's from the Weitzman Institute that our Project ECHO Learning Network has been developed and is broadcast on a weekly basis. So let me talk to you today about what Project ECHO is. And I suspect many of you, although you haven't had experience with ECHO, may have at least heard of it. But it's important, I think, to understand where ECHO came from and why it was developed. And we have to go back about 15 years to Dr. Sanjeev Arora, who is a gastroenterologist in Albuquerque, New Mexico. He's a brilliant man, a passionate man, and he's the founder of this entire thing that we now call Project ECHO. And in the early 2000s, he realized that he was the only gastroenterologist specializing in hepatitis C who was willing to see patients with hepatitis C who had Medicaid or were uninsured. And as a result, being in Albuquerque and New Mexico being a large state, he had patients coming far and wide, some driving up to 3 hours or more each way just to get to see him. He had long wait lists, and with patients often progressing and having progressing to more advanced stages of cirrhosis before they could even get in to see him. And so he got the simple and yet totally transformative idea back in early 2000s that rather than have every patient in the state who needed to be seen come all the way to Albuquerque to see him and his team, what if instead he could host a weekly video conference, and the primary care providers from the federally qualified health centers and other clinics who were taking care of those patients could join onto that video conference, could present the cases and describe what they were seeing, and he and his team could give them advice and guidance. And by doing that over time, those primary care providers might be able to become expert enough to treat them themselves. And accelerate up to the year 2011, Dr. Arora and his team published the lead article in the New England Journal, which showed that he was right. Not only were the primary care providers able to treat patients with hepatitis C with guidance from Project ECHO, in fact, the results that they got were as good or better than the results being obtained in the specialty clinic. And the format that he established was rigorous and very focused, but very effective. The key elements of his ECHO sessions were that several cases were presented by primary care providers each week, and that the cases were presented to an expert team, which was comprised of a range of different specialties. For hepatitis C, it was a hepatologist, an infectious disease specialist, a psychiatrist, a pharmacist, a nurse care manager, and others. And also during the 2-hour session, some member of his team, usually him, would present a brief didactic about a topic that was relevant to hepatitis C. And by the combination of frequent cases being presented and didactic sessions, the primary care providers would gradually learn and become confident and competent to manage the condition that they were taking care of. And so, from that initial experience with Project ECHO Hepatitis C, many new ECHO clinics were born. Dr. Arora and his team realized that if this could work for hepatitis C, it could work just as well for other conditions that were common in primary care, and that primary care providers could manage. And so since that time, over a dozen different Project ECHO clinics developed out of New Mexico and were offered, one in rheumatology, several in different behavioral health areas, one focused on chronic pain management, and a variety of others. So right around that time at CHC, we learned about Project ECHO and were excited by what we had read in the New England Journal and decided that we would seek to replicate that model. And one of the great things about Dr. Arora and the University of New Mexico is they not only did they encourage replication, but they actively supported it. So I had the privilege of flying out and spending several days with Dr. Arora and his team and learning all about how they did what they did. And we came back to Middletown, Connecticut, and developed a similar model. Because although Connecticut is not a rural state like New Mexico, and we have storied institutions like Hartford Hospital and Yale and UConn, we had similar problems getting patients in to be seen by specialists when they had Medicaid or lacked health insurance. And so our Project ECHO, about 6 months later, started off focusing on patients with hepatitis C with our own expert treatment team, and has now been going on since 2012. We built it with a similar technological infrastructure, and I think all ECHOs share this in common, that they use some sort of a cloud-based teleconferencing platform. We use something called Zoom, which is an easy-to-use system that you can access from almost any device, from a smartphone, from an iPad, from a laptop, or even from a Polycom system. It really doesn't require any technology. We've had providers join from their laptops, is the most common way, but we've even had providers join from their cars or from airplanes. As long as they have Wi-Fi or 3 or 4G connectivity, you can join from anywhere. And we obviously don't encourage people to join from their cars, at least not when they're driving, but I think it demonstrates how easy it is to join on to the sessions. So there's a lot of features that we've built into Project ECHO and that are common across the different replication sites that have created new ECHOs. But I think some of them that I want to emphasize are, obviously live participation and case presentations. The primary care staff and the behavioral health staff are learning because they're hearing their colleagues present cases from real primary care. And that's what makes this different than a typical CME. It's not a lecture. It's real people, real primary care providers, behavioral health providers presenting real cases that if they don't sound just like the case you saw today, they'll sound just like the case you probably will see tomorrow. Lots of very common things that you're facing that are challenging. Depending on the specific specialty, there'll be a range of specialists on the other end of the video conference that are serving as the expert faculty. One of the things that we focused on is integration of behavioral health and medical, and we always include on our expert faculty a range of providers from both behavioral health and medical, and we encourage both primary care, medical, and behavioral health providers to co-present when their cases are being discussed. So one of the things that's unique about the Weitzman's Project ECHO, and I think about the direction that ECHO can take, is there's really no reason for it to be geographically localized. The original Project ECHO was produced by University of New Mexico for New Mexico providers, but I think gradually many ECHO providers, including us, have realized there's no reason why the provider joining on couldn't be in Montana or in North Dakota or anywhere else in the country, because the cases, while there are certain regional differences in some respects, the cases have an enormous amount in common. And so since 2012, our Weitzman ECHO Learning Network has gradually grown with up to 7 now different specialty conditions that we offer ECHO for. We have 52 health centers that are joining from 9 different states and the United Kingdom, and to date about 1,100 cases have been presented, and in a range of different specialties. And although we started with hepatitis C, we added HIV. Chronic pain is one of our most commonly subscribed. We have one focused on quality improvement, but the one that I want to talk about today and really switch for the remaining time that I have is our newest ECHO, which is focused on pediatric and adolescent behavioral health for school-based health centers. Because as we've spoken with our primary care staff and our providers, one of the things we've come to know that nowhere is it more critical to integrate behavioral health and primary medical care than in the school-based setting. And I challenge our providers to ever practically show a case that doesn't have both a behavioral and a medical component to it. And yet most of you will probably agree that in many cases those two disciplines have been siloed. We don't even speak the same language. Sometimes we use different terms to describe our patients or our clients. Rare is the medical provider who can read and understand a behavioral health provider's care plan, and I think the reverse is true as well. So the Behavioral Health Project ECHO for Pediatric and Adolescents in School-Based Health Center, we started it in January as a pilot, test of concept to see whether or not our school-based health center staff would find it useful and helpful. And we designed it very similar to what I've described, with twice monthly sessions, combined behavioral health and pediatric faculty. Some of the faculty work in school-based health centers. Some of them are from academia. One of them is a frontline pediatrician. We have a range of different expertise sort of built into the faculty team. We're directing it specifically at middle school and high school school-based health center participants. And they are a range of different types of behavioral health providers as well as primary care providers, most of them nurse practitioners. And again, like our other echo sessions, usually 2 to 3 cases are presented with a brief 20-minute didactic. And the didactic curriculum for pediatric and behavioral health, the sessions are about 20 minutes each. And these are some of the topics that are discussed: assessment, school boundaries, legal and community boundaries, anxiety, depression, ADHD, probably things that sound very common to those of you who indicated that you're working in a school-based setting now. These are just some of the topics that have been presented during our behavioral health and adolescent school-based ECHO pilot that we conducted over the past 6 months. With all of our ECHOs, we administer knowledge assessment tools, questionnaires, to all participants prior to starting and then after. Now, we've only been doing this for a couple of months, but already those knowledge assessments demonstrate that the participants, both medical and behavioral health, are gaining knowledge in some of the topics that we presented, such as the boundaries that I mentioned, anxiety and initial assessments, and starting to speak the same language. So you may wonder what types of conditions and what sort of things are being discussed. This is an overview of the conditions that have come across our Project ECHO session over the last 6 months, with ADHD being the most common, but you can see depression, substance abuse, oppositional defiant disorder, panic, dysthymia, autism, anxiety. These are the behavioral health diagnoses. There's a range of medical diagnoses from asthma to migraine headaches to sleep problems that have come across as well. So I thought I would do 2 things. First, I'll give you an example of a real case, because I think I can talk about ECHO ad nauseum, but I think it's hard to really get a sense of what's going on without actually sinking your teeth into a case. So here's an example of a real case that was presented a couple of weeks ago. And the topic, according to the primary care nurse practitioner who was seeing the child, was ADHD. And her question was, what should be done to help a patient who's presented with ADHD symptomatology and signs of other conditions, but also has a mother with a history of terminating therapy? And obviously there were many more details that were discussed. Generally, the primary care provider presents for about 5 minutes. But to summarize, what she presented was a 9-year-old female who was struggling with relationships at home, possible ADHD. She had a history of witnessing domestic violence in her house, and she was in individual therapy for acting out behaviors at home, primarily towards her mother, but past therapy attempts had been terminated multiple times when the mother thought that they hadn't been effective. And some of the ADHD symptoms have been demonstrated, but there was something else going on as well, the provider thought. So it's hard to summarize this because this probably took 20 minutes for the discussion to carry out, but the faculty and the participants reviewed the case, discussed it extensively, and talked about the necessity of family engagement and treatment, and more of a focus on trauma treatment for the history of domestic violence exposure. They recommended in-home family therapy as attendance had been a barrier to treatment, and the symptoms were occurring for most of the case only in the home. A second case was, the topic was anxiety, and the main question here was how I can help my patient manage anxiety and deal with chronic migraines. What medications would you recommend? And they discussed the details of what treatments had been tried. This was a middle school aged female who had anxiety, which seemed to be controlled, but was complicated by chronic recurring migraines. And so in this case, the faculty and the ECHO participants all talked amongst themselves and explored best practices, including cognitive behavioral therapy and family therapy. And there was a discussion about the possible need for a medication consult. And the pediatrician on the faculty team led a discussion about the approach to managing migraine headaches and discussed the correlation between stress and somatic symptoms. And again, I'm summarizing a 20-minute discussion, but I think it gives you a good feel for what's going on. So I'm going to try something. I'm not sure if this is going to work, but maybe the team actually, and this is totally random, luck, we happen to have our pediatric and adolescent Project ECHO going on right now. And if you can see on my screen and hear the audio, this is a live ECHO session. I'll just leave it on for maybe 30 seconds so you can get a feel for what it sounds like. So speaking now is the pediatric and adolescent psychologist and the lead faculty member.
And when I asked her that, I said, so what would happen if you were my doctor? And I said, look, if you were switched. I said, if you were therapist.
is a nurse practitioner who's working in one of our local middle schools.
Well, I would tell you that if you're for a teenager, this is normal teen stuff.
And across the top, you can see screenshots of some of the participants. Some of them have cameras, some of them don't, but most of them are out in their schools as we speak. So, wow, I was a little worried that that might not work, and I just happened to look at my calendar and see that the session was going on, but hopefully you were able to hear that and see it. And I think if nothing else, it demonstrates just how easy it is to do Project ECHO. Every one of those behavioral health providers and nurse practitioners is sitting at their desk in their school-based health center, and you can see they're talking to a friendly, laughing, very accomplished faculty that's giving them guidance on some of the tough cases that they're seeing. So with that, let me get my slides. There we go. I think I'll end. I think that's hopefully gives you an idea and an overview of how ECHO works. You know, I will say that this adolescent and school-based behavioral health ECHO is available, and we're actively looking for additional partners and people who would like to join on. One of the things that we've experienced, although we originally started Project ECHO internally for our organization, as one of my previous slides indicated, we've now had practices join from all over the country. And what we found is that as new practices and new states come on, it only makes the ECHO experience more rich and varied. And cases coming in from California and Washington State or Northern Maine add to the richness of the experience and add to the learning. And so, you know, we're excited that this project has been successful so far, and we will be, we take the summers off since it is a school-based focused initiative. Our ECHO will be starting up again. It'll be ending, I believe, next by the end of the month, and then starting up again in September. So with that, I believe the agenda is for me to take maybe one or two questions and then turn over to our next presenter. So with that, I'll stop sharing my screen and say thanks for your attention.
Okay. We'll give you all about 30 seconds. If you have any questions you want to submit directly to Dr. Anderson, we'll also collect and talk about questions that appear in the chat box at the end of the presentation as well.
Just a quick check. Were you guys able to see the video screen?
We were. It was wonderful. Thank you.
No, thank you.
Yeah, I was as well. Thank you.
Anytime there's a new technology that you're working into a presentation, I always get nervous because too many times it doesn't work, but great, I'm glad you were able to see it.
Okay, don't see any questions rolling in right now, so I think we're going to go ahead and pass the presentation over to Ms. Hopewell, and then we'll go back and see. Please do feel free to enter any questions into the chat box at any point. We'll come back at the end, and either presenter can answer questions.
Was article, and it was not really smart. She's like, I really didn't stop, but then I thought, well, how fast? And her eyes were all before you do that, and she didn't stop, and she.
Okay, so this is I'm Jillian Hopewell, and thank you very much, all of you, for attending today. I'm excited to be here with you and talking about Project ECHO. And I want to let you know that our organization, the Migrant Clinicians Network, we're really at a much sort of younger phase of our integration into a Project ECHO process, which I think could be interesting for you as people who may potentially be interested in adopting Project ECHO or components of it, because Dr. Anderson is much further along in the process than we are, and so it's just kind of interesting to see kind of the continuum of how you can go with it. But what I want to talk to you about are some other ways that we have been thinking about applying Project ECHO, as well as some of the ways that the University of New Mexico has applied Project ECHO in working with some different types of provider groups, which may be sort of spur some thinking for everybody. So before I go into all of that, I wanted to just give you a really brief background into the Migrant Clinicians Network, because it is relevant to the whole conversation, particularly this notion that Dr. Anderson raised of the isolation that sometimes accompanies primary care in a number of different settings, and then this issue also of the geographic range, and we have been thinking a lot about how to expand the notion of Project ECHO and really bring in a number of diverse geographic areas. So the Migrant Clinicians Network, we are a national association and actually international association of clinicians who work with migrants. We started working primarily with farm workers, but that has since expanded into really looking at any mobile underserved population, because there were so many crossovers with farm workers and people migrating for carpentry work, for fishery, for a whole variety of things. There's a number of different services that we provide as a national training and technical assistance organization, and there are also a number of direct services that we do. We have a project called Health Network, which is actually a bridge case management system for mobile patients. So if you are a patient with tuberculosis, your provider would enroll you in our system, and our case managers would then transfer your records and find you care where you end up going next. And we work with patients with all different variety of challenges. It can be infectious disease, it can be behavioral health issues, it can be pregnancy or chronic disease, a number of other things. So, and then there are a number of other programmatic things areas in which we work. We were founded, we're celebrating our 30th year right now. And then there are a number of different things that we do within the purview of the training and technical assistance and the resource development and policy and programmatic work. It gives you a little sense of that there. So the Migrant Clinicians Network was founded, like I said, in 1984, and it was founded by a group of 3 clinicians who met at a conference in South Texas, and they were all working in migrant health specifically, and all really sort of, as they got together and started talking, they all were feeling the same sort of geographic and professional isolation, and decided at that juncture that there was a real benefit to forming as a network. And that notion of being a network and developing peer support and sharing resources and developing programs as a network is really at the heart of what the Migrant Clinicians Network still does. And one of the things that we're constantly really striving for are additional opportunities to bring people together and to allow people to connect with one another across those geographic divides. And so it really was a natural, it was a kind of a aha moment when we first encountered the idea of Project ECHO, and it really made a lot of sense to us. And this actually is a map of the all of the different places in which MCN has worked just over the past year. A lot of this is with our Health Network program, but it gives you an idea of the geographic spread of the work that we do. All of these points represent primary care providers who are working with migrating patients. And so they all have that element of commonality, and yet there's a lot of isolation there. So when we became aware of Project ECHO out of the University of New Mexico, like I said, there was it was kind of a spark, and it really made us think about ways in which we could potentially work together. And for us, there are 3 main areas in which we feel like there's potential for them, and we're actually moving forward in a lot of these areas, but for us as MCN to work with Project ECHO and work with the concept of Project ECHO. And one is with community health workers, and I will be going into a little bit more detail about the community health worker initiatives that Project ECHO has done specifically, and then some of the ways in which we are thinking about employing it as well. The second are clearly primary care clinicians, as Dr. Anderson covered. I'm not going to go into that because Dr. Anderson covered it really well, but clearly that's an area in which there's a lot of potential in the realm of migrant health. And then the third area, which I am going to go into a little bit more, is a project that we're in the process of developing that's looking specifically at medical directors and the clinical leadership at federally funded health centers. So on the community health worker side, this is very interesting, and this is the Project ECHO out of the University of New Mexico has developed several different projects using Project ECHO, the Project ECHO concept to work specifically with community health workers or promotoras. And this is one they have specifically looking at the issue of diabetes. And just a few things that came, sort of the way that the model has developed for this particular group of community health lessons. The way they structure it for the community health workers is they do 3 days of an on-site intensive instruction. And then this tends to be very hands-on skill-building types of instruction. So you can see, blood glucose testing, foot exams, and sort of real hands-on things that can be done by community health workers who then have a linkage with community health centers or other primary care sites. So they do 3 days of this on-site intensive instruction, and then they engage that same group of community health workers in weekly teleconferences and weekly Project ECHO, just as Dr. Anderson showed you, weekly teleconferences for 4 months, where the model is the same as what Dr. Anderson discussed. So there is interactive didactic instruction, which is followed by patient case presentations by the participants. And the curriculum topics are supported by the AADE-defined competencies so that in the end, the lay health workers, the community health workers come out of that whole process with a certification. And so this is, again, work all done out of the University of New Mexico by the Project ECHO staff, and they have found it to be really very effective. They've since expanded that, and they've developed projects specifically around obesity prevention, which ties in, obviously, to diabetes, and then looking also at substance abuse. They've also done some very interesting projects, and if you want more information about it, just let me know, and I'll send you over to the correct person over at the University of New Mexico. But they've done some really interesting work with linking up with the prisons and developing community health workers within the prison systems to address some issues. So for our organization, for the Migrant Clinicians Network, we are engaged right now in it's actually a webinar series specifically for community health workers. It's all in Spanish, and it's fundamentals of public health. And even before we started this particular webinar series, we really felt that Project ECHO would be an effective tool for engaging community health workers. But it's become even more apparent as we've developed this session. And one of the things that that is very apparent to us is that the community health workers who are participating in these are, well, one thing, they come from all over. We actually have international participants. We have people coming from, or coming virtually to us from Peru and from Honduras and from all over Latin America, and then all over the United States as well. And there's a deep hunger that's very clear among this group for further conversation, and specifically for conversation with their peers. And I think that the webinar format, provides a lot of really great opportunities, but it doesn't allow for that sort of interactive peer-to-peer networking. And so it's really become obvious to us that the next step in all of this is the development of Project ECHO, which was something we were looking at already, but now really has kind of gathered up steam for us. And we're currently exploring, because again, so as I'm sure all of you experience, so much of funding is categorical. So in some ways it would be great just to engage these community health workers in an overall discussion of public health and their work. But with categorical funding, we're looking specifically at some HIV, cancer prevention, behavioral health, and substance abuse. So those are the areas in which we're looking to explore the development of community health worker Project ECHO. And then switching gears quite a bit, actually, I wanted to go into a little bit of what we're looking at for the employing Project ECHO with clinical leadership in federally funded health centers in particular. And this particular project is linking directly with, and some of you may be familiar with the Managing Ambulatory Healthcare course that is typically put on by NAC with the faculty from Harvard. And the Migrant Clinicians Network has partnered recently with NAC in the development of a couple of different managing ambulatory healthcare courses. We add on, in addition to the regular curriculum that they are working with, we do add on some migrant-specific information. And we have been then in discussions with NAC and with the faculty from Harvard about the development of a medical director-focused Project ECHO. And in this model, it will include, so we would take a group, a subgroup of the participants in the managing and the MAC course. Well, let me just back up a minute on that as well, that what has come out of the MAC courses and in a lot of the evaluations and the discussions after the course is that the course itself is a week long. It's very effective. It's evaluated very highly. People find it very useful, but then there is that lack of follow-up piece to it. So people then go, these are all relatively new leaders in health centers, and they go back to their site, and there is not an established mechanism for continuing those conversations and bringing back questions and other concerns that may arise after you get back to your site. So the concept here, and this would be based on a MAC course that's going to be taking place in January. So it will all be happening in 2016. But the model will include, in this concept, it will be accredited as all of the Project ECHO. That's sort of an underlying component of all Project ECHO clinics, is that they are typically accredited for clinical providers. The concept here is that we would do a once-a-month tele-ECHO clinic, in quotes. It would be essentially an clinical administrative clinic. It will be focused around key topics, which I'll bring up here in a second. It fundamentally employs the Project ECHO case-based learning concept, and in addition to some of the didactic sessions, and then it will include the course faculty as well as outside experts, depending on the topic that is being addressed. And so, and then the idea is that we'll have about 20 members at the beginning. And the topic, so the medical director clinics will be structured around the key elements of the MAC course, which include all of these components. And the concept as it is laid out now is that the monthly clinics, these topics are all covered during the MAC course, the week-long in-person course that these people will all have participated in. But then we will have specific ECHO-focused clinics on these specific topics, and we'll bring in outside expertise as needed on those different pieces. So this medical director or clinical director Project ECHO is another way in which we really envision this peer networking model as a really powerful tool to be able to both increase knowledge, but also really increase professional satisfaction. And that's one thing that I don't believe that Dr. Anderson addressed in his conversation, but is something that the folks at Project ECHO and the University of New Mexico have also looked at, is recruitment and retention, and the impact that participating in a Project ECHO clinic has on professional satisfaction and the recruitment and retention of clinical providers in primary care settings, and particularly in federally funded health centers. And this whole bringing people in for ongoing learning and exposure to new research, as well as the ability to then move on and become a real leader among your peers, is something that is deeply satisfying, I think, for a number of clinical providers, and something that's very exciting for our organization as a clinical network to be able to provide that opportunity. And that actually is all that I have prepared to speak about. I'm happy to answer any questions about our process, and I know Dr. Anderson is as well.
Thank you so much, Dr. Anderson and Jillian, for those wonderful presentations. At this point, like Jillian just mentioned, we're going to ask attendees if you have any questions for either presenter, you can go ahead, again, as a reminder, to put those in the chat box located in your GoToWebinar control window, and you can type in your questions, and we'll read them off to the presenters if you have any. And while we're giving you some time to do that, we'd like to remind you that we are here at the School-Based Health Alliance celebrating our 20th anniversary, and we'll be hosting our national convention from June 16th to 19th in Austin, Texas, to celebrate 20 years of collective impact for student success. You can register for the convention on our website, and we hope to see you in Austin. School-Based Health Alliance is a membership organization, and we rely on members to support our work as the national voice of school-based healthcare. If you're not currently a member of the School-Based Health Alliance, we hope you consider joining. We offer two options for membership, individual members and organizational members. To learn more about those benefits or to become a member, please visit our website. Okay, we're going to give another minute and see if any questions come up. Okay, we have one question that came in for Jillian.
So we had Lois Wessel ask, is there connectivity issues with some of the promoters out in the camps? We still have connectivity issues in DC on the mobile vans.
Well, the nice thing is that, as Dr. Anderson mentioned, most of the Project ECHO clinics are taking place on the Zoom platform, which is it's much easier to access than many other formats. It's not foolproof by any means, but it is, you can access it using cellular technology and not wireless technology. So so it's better. Again, it's not perfect, and so there definitely has to be some experimentation that goes on about, where people can best access it, and it may be that they're not able to access it truly out in the field. But a lot of people have had success accessing it out into the field, and the folks at New Mexico use it quite a bit internationally as well, and have found it to be very very accessible for their international participants.
Thank you, Jillian. We have a few more questions. I'm just pulling them up, 1 second. The next question is to either panelist. What are the costs involved with Project ECHO implementation?
You want to tackle that, Dr. Anderson?
Sure. I think there's two main costs. The infrastructure cost, which the ECHO hosting entity needs to take on, which can be fairly substantial. And we've had this infrastructure, Zoom, and the faculty and the staff that manage it up for a while. But we had estimated at one point that was in the range of $300,000 to $500,000 to develop an internal ECHO infrastructure, and that's probably come down since we looked at that. And largely, what that infrastructure includes is the video conference system, and then more importantly, the staff to maintain the projects, to solicit cases, to do all of the back-end management, and run the week-to-week process, recruit the faculty, train the faculty, and all that sort of thing. And we developed our ECHO infrastructure largely through grant support from a range of different sources, private philanthropic grants from different foundations, and increasingly we've been funded by Medicaid state agencies such as Delaware and the state of Colorado to develop and create specific echo interventions for their states. And one of the roles we've been taking on is kind of, don't reinvent the wheel. Work with us and we can develop and host an echo for you, joining you with whoever you want, so that you don't have to constantly reinvent and reacquire infrastructure that already exists. And in terms of cost to the providers, there really aren't any, other than the share of the total administrative cost. And so, in general, many, like I said, states, Medicaid agencies have, for example, in Colorado, funded us to develop their Project Echo and to host it. We have now actually over 70 providers in the state of Colorado joining a Project Echo, and it's completely free for them, and they're funded and hosted by their state Medicaid agency, and we do the back-end work to create and to produce that Project Echo for them. So the only real cost to the end user is the cost of high-speed internet or 4G or whatever system you're using, but there's no other technology.
And then, of course, there's just the time, which in some sites is more of a challenge than others, because typically most of the echo clinics, I don't know, Dr. Anderson, if yours run this way, but they're about an hour and a half, and so for some places, freeing up their providers for that amount of time.
Yep, I'm glad that you mentioned that, and that is the principal sort of unaccounted for cost, that depending on your cost model, if you're a fee-for-service and every lost productivity visit is a loss to your bottom line, then this can be considered costly. We do try to host all of our echo sessions during or close to the lunch hour. Whenever possible, our school-based session runs late in the afternoon when most of our schools are either heading out of session or towards the end of the day and winding down. But there's no question, I think, from the CFO perspective, if your financial model is based on visit production, then this can be a pretty significant cost. And for the practices that are more value-based, accountable care, doing something like this where you're taking on additional scope and becoming expert in a new area, such as use of buprenorphine or pain management, there's more of I think, a balanced return on investment argument that you can make for Project Echo. But it really depends on the payment model, and that's a topic that's really evolving across the country as payment reform takes hold in different speeds in different locations in different states.
Great, thank you. We have another question that came in. This says, hi, great presentations, thank you. Can you talk a little bit about HIPAA with the school-based and other echo clinics?
Sure. HIPAA is important. I'm glad that you raised it. We sign a memorandum of agreement and a business associates agreement with every clinic that joins us, which allows for the exchange of information. And then everything from that point, after the basic case information is conveyed to our staff, is completely scrubbed and de-identified, so that anything that gets put up on screen, anything that's discussed during the session is completely de-identified with no identifiable patient information. And we make an announcement at the beginning of every echo session reminding people about HIPAA, that this is an educational intervention and that no PHI is to be discussed at all. And so every provider, when they submit their case, we assign them something called an echo ID, and so they'll refer to that case exclusively as this is, patient echo ID number 153, presenting with a history of anxiety, depression, and X, Y, and Z. So, but we're very, very careful about that. And because this is an educational intervention, and because there's no exchange of PHI, we stay in complete compliance with any HIPAA regulations.
And it's also important to point out that as Dr. Anderson was just saying, it is an educational intervention. So it's not a consultant type of relationship. It's a peer networking education, and so it's not telemedicine, right? So you're not diagnosing or treating somebody at the distance end, at the virtual end, but it's an exchange of information. I don't know if you want to elaborate on that. I feel like I'm not articulating it very well, but
yeah, no, I think that's exactly right. It is an educational intervention, and everybody is learning. It's case-based learning, so we're learning from the specific cases. And although the specialists are discussing a specific case, and in many cases saying, I would recommend you X, Y, and Z, It's the primary care provider who is learning from them and ultimately responsible for implementing whatever care plan they choose, which can be informed by the education and the information that they've acquired during the session. But we make that point at the beginning of every session as well, that you're not being told what to do. You're being given advice and guidance and knowledge, but ultimately you maintain authority to decide what you want to do.
And that also brings up an interesting point, which is that the Project ECHO team at the University of New Mexico, I think, is about the most generous with their intellectual property as I've ever seen any group be. And they have fully developed systems that they will share with organizations that do come on and become official partners with them, and that really go sort of step by step of how to set this up, and the different documents that you should have in place, and how you go about training your participants. And it is fundamentally a very simple concept, but then in practice, there are definitely lots of details that need to get taken care of, and that work has really already sort of the foundation of all of that work, I'll say, has been done, and the University of New Mexico is quite willing to share that information. So I have found them to be very generous and helpful to work with, and the development sort of as you're starting things up and trying to make this happen. So if it feels overwhelming as something that you might consider wanting to do, it should. There is a lot of work, but a lot of that work, there's a lot of resources as well.
Great, thank you so much. That about wraps up our time remaining for questions. I just wanted to go to a few closing reminders, and also to please ask again that if you're viewing as a group, to go to the chat window and type in the name of the person registered and the total number of additional people in the room. For example, Tammy Jones +3. Thank you again so much to our presenters, to Dr. Anderson and Ms. Jillian Hopewell. This presentation has been recorded and will be archived on our website. If you would like to request support and technical assistance related to video conferencing technology or ECHO, please send us an email at programs@sbh4all.org. I'd also like to ask that you please take a moment to fill out 3 evaluation poll questions that will appear on your screen. Your feedback is vital in helping us craft presentations and tools that will best serve you. Our first poll question is, did this presentation meet your needs? Please take a moment to respond. Great, thank you very much. The next question is, did this presentation provide you with usable ideas and/or techniques? Please take a few moments to respond. Thank you very much. And our final question is, would you recommend this webinar to others? And please take a moment to respond. Thank you again for attending our webinar today, and our sincerest thank you to Dr. Anderson and Jillian Hopewell for the informative presentation. Have a wonderful afternoon.
Thank you, everyone.